Hello, everyone. Welcome to Placebo. I'm Logan Richards, and this is my sister.
And I'm Kaylin Richards.
And this week, we're going to try and answer the question, what is pain?
That's a broad question, I'm afraid.
Yeah, it's really broad, and we're going to get to some parts, but as usual, we probably won't cover everything, and you'll probably need to do more research on your own if you're still interested.
Probably.
Okay, I got stung by a bee just the other day, and I forgot how bad it hurts to get stung by a bee.
Super hurts.
Have you gotten stung by a bee recently?
Last time I think was a couple years ago, and I was hiking, and I had nothing I could do about it.
I didn't do anything about it either.
Well, I thought I wanted to put ice on it or something because it was so painful and it was swollen up.
Yeah, I did end up putting ice on it, but I really forgot how bad it hurts.
It's really painful.
Okay, so let's talk about what that pain is.
Mm-hmm.
Before we start, I want to say that the champion of teaching people about pain
Yes.
is this guy. He's a physical therapist and a pain scientist named Lorimer Moseley.
Is this the guy we watched on YouTube?
We did watch a video of him, and
has a
there will be
lovely-
a link to it on the show notes.
I was going to say he has a lovely Australian
Oh
accent.
yeah, he's super Australian.
Yeah, very cute.
Very cool. We'll post the link to his TED Talk on the show notes, but he is super good at teaching people about pain, making it relatable. And I want to say that we will be nowhere near as good as him, but we will try our hardest.
But still listen to us, and then you could listen to him too.
Yeah, after the show, go listen to his TED Talk for all the other questions you have. Okay, so let's talk about the definition of pain.
Okay.
Did you know there's a place called the International Association for the Study of Pain?
It's a place?
It's a place, and it's in Seattle.
Oh.
And they decide what the definition of pain is.
We're in Seattle, we should say.
Yeah, well, people
Yeah.
probably know that because not too many people listen.
Someday, maybe. We're in Seattle.
Okay, so they say that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage.
Okay.
What do you think about that?
So, I mean, that seems pretty good. It could be, sometimes, people will wince or flinch in anticipation of pain. Like they think they have received a shot, but they haven't actually gotten it yet.
Right.
Yeah.
Are they having pain at that point?
They think so.
Pain is complicated. The first thing I think that we need to say is that pain is what they call an output of the brain, meaning that it's a perception of things that are happening around you. Mm-hmm. And the way that we figure out that perception is through a bunch of different inputs. And those include inputs coming in that are sensing things on your body, but it also includes things like is the situation that's happening emotionally stressful, or do you have past memories that are bad about the same type of situation? So there's all sorts of different inputs that help the brain decide if your body should be in pain or not.
Right. So, like well, no, go on. I won't give an example.
Okay.
There.
Well, so basically what pain is an alarm system. Mm-hmm. And that makes sense, right? Because things hurt and then you stop doing those things.
It's your body protecting itself.
Right. It is. So...
But maybe it's too protective sometimes.
Yeah, well, that's the thing about nerves, is that sometimes they can be wrong. And
anybody can be wrong. That's
just... And because of the way the brain works and how many inputs come in to help the brain decide if it should make you feel pain or not, sometimes it gets it wrong. Mm-hmm. So let's first talk about the way that the alarm system works. Mm-hmm. Basically, all throughout your body, you have sensors, and these sensors are called nociceptors.
That's a fun word to say.
Yeah. So the root word of that is, I think, nocere, which is Latin for to hurt. Or
do you think
like
noxious is the same root?
Yeah, it means noxious stimuli.
Oh, okay.
So yeah, so you've got these danger receptors, which are nociceptors, and they help your body sense when there is tissue damage. Mm-hmm. But the brain doesn't
if I got a cut on my finger. They would be signaled.
So they would be signaled, and then the signal would run in the nerves up into your spinal cord, and then spinal cord to the brain. And then your brain would think about all the inputs that it's getting. And if it's simple, like you just cut your hand, the brain will probably say,
that could hurt really terribly.
Yeah, there's been some danger here. We might have some tissue damage. I'm going to make that person feel pain so that they'll pull their hand away.
Notice that they've cut their finger while they're chopping vegetables.
Right. So an interesting thing about the sensors is that there's different types of them.
The nociceptors?
Yeah, there's lots of different types. And it's more complicated than we'll probably talk about. But there are some that react to mechanical stress. So meaning like getting squished.
Or pulled or something.
Or some type of force on them. And then there's others that respond to kind of chemical imbalances, let's say. And a good reaction of that is with the bee sting.
Because it's poison?
Yeah, the bees put in a type of poison that interacts with nociceptors.
Because really it's like, the stinger is just like a tiny sliver. That wouldn't hurt very much.
Yeah, the stinger, well, they have barbs on them. Yeah, but if you just got poked by that, it probably wouldn't be that painful. What's painful is that they have a poison on them.
So sore.
That interacts with the nociceptors. And that starts the inflammatory response.
Which is why your hand swells up.
Right.
Or wherever you got stung, yeah.
Yeah. The thing with nociception is that they're not pain nerves. There isn't pain that they sense and then they send the signal of pain to the brain. That's not how it works. They sense danger either through mechanical forces or through chemical changes, and then they just tell the brain about it.
Like the finger has been smashed.
Right. Well, they'd say, we've got some weird pressure changes
There's
here.
A sudden pressure around the finger.
And the brain has to figure out if that's supposed to be painful.
And then maybe you would look at it and notice your finger is in the car door.
Right. So, and vision is one of the things that would help. Because sometimes you would hit your hand or squish it or something, and you think it's going to be really painful, and then you look down there and your hand looks fine, and it hurts less.
I remember one time I cut my toe really badly.
Did you?
And I didn't, I didn't see it.
I remember.
Do you remember this?
Time.
I was talking on the phone, and I had bare feet, and I kind of thought my toe was itching, so I went down and was like rubbing my toe, and then I noticed there was like blood running all down my hand, and it was a big mess everywhere, and it was cut really badly. But until I looked at it and saw what was going on, I didn't even feel it. It just felt like a little itch.
And that's a great example because likely what was happening was since you got that cut, you were bleeding, there was a reaction from the nociceptors. But that reaction it may have not actually made it all the way up to the brain, but for this example, we'll say it gets all the way up to the brain, and the brain says, well, we're just sitting here reading and everything looks fine.
I was on the phone. I wasn't reading.
Oh, okay. I figured you were reading. We're just sitting here on the phone and everything looks fine. So this is a false alarm. And that's why you didn't feel pain. But then you saw it and you're like, oh, wait, I've been getting these nociceptive signals.
Yeah.
And I might actually be in danger here.
And then I almost passed out because I was bleeding everywhere.
Right.
I didn't know what happened.
So that is a very good example. One thing that they like to say, nociception is neither sufficient nor necessary for pain. Does that make sense?
So if there's nothing going in the tissue at all, your brain could still decide that
you can
you're having
still
pain
feel
there.
pain without the input from the nociceptors. And if you do have input from the nociceptors, that doesn't necessarily mean you're going to feel pain.
Right, because my toe just felt like an itch.
Right.
I remember that, and I was so shocked.
So that is complex. And there's a lot of interesting stuff about nociceptors. So I'd say if you're interested about that, look further into them.
Good idea.
Okay. The next part of pain.
You should spell nociceptors because that's not very common. Maybe?
Yeah.
No?
I could post that.
Okay. It'll be on the website.
The next part of pain is we have to talk about how it makes its way from the nociceptors up to your brain.
Okay.
Because the reason that we have to talk about that is there is an important way that nociceptive signals can be blocked before they even get to your brain.
Is that what happened to my foot?
Well, I have no idea what happened to your foot.
Why didn't I feel very much?
It's possible.
Okay.
So there's these things called synapses, which are gaps in between the nerves.
Right.
So unlike an electrical cable that you might plug into the wall,
which is continuous.
right, nerves nerves talk to each other through small gaps. And at those gaps, they spit out chemicals called neurotransmitters,
which
go across the gap to the new neuron. And that's how the signal gets transmitted from neuron to neuron.
Yeah.
So the gaps are important because...
It's like a relay.
Yeah, it is. So say you got that pain signal from your toe and it's going up your leg and then it gets to the spinal cord, and at that point it needs to jump to another neuron that's in your spinal cord in order to continue its way up toward the brain.
Right.
So one way that
if I had a spinal cord injury, it's not going to go.
That's true, yes. But not what I was going to say.
Okay.
So nerves go in two directions. They either go towards the brain or they go away from the brain.
Right. The brain is sending things down or information is coming up.
So one thing, at that gap, there can be what's called an inhibitory neuron. And so these are signals coming down from the brain. And if for some reason the brain doesn't want to feel pain, what happens is that the inhibitory neuron puts chemicals into that synaptic gap and stops all the signals that are coming from the nociceptors from getting to the spinal cord and getting up to the brain.
Would that be an example of people like playing sports that they're really into? They're having a lot of adrenaline and they don't notice necessarily an injury right away.
Right. So that is not exactly an example, but it's the same thing. So what you're referring to is called stress-induced analgesia. Meaning that there's no pain because of the stress. And usually that has to do with adrenaline and endogenous opioids. And that is exactly the reason that your brain might send down a signal and say, don't let any pain up to the brain.
Like, I'm busy playing this sport right now.
Right. Or, well, not necessarily. Probably not.
I'm very busy sporting.
Probably not in evolutionary terms.
I need to win this contest.
Exactly. So, yes. So that is one way that pain can be modulated.
Controlled.
Yeah, which is basically what that means. There's a ton of ways that could happen. Another that's interesting that you have to talk about when you talk about pain is the gate theory. Have you heard about that?
Yes, but I don't... Is it like you have to get enough of a signal for it to travel across the synapse? Is that it?
So the gate theory was described by... two guys in the 60s, Melzack and Wall. And what's interesting about... So the gate theory, the way they described it originally, apparently is no longer totally true. But this is almost like the opposite direction of that pain modulation I just told you about.
With the brain sending something down, saying no pain right now.
So this uses an inhibitory neuron also, but... The inhibitory neuron is in the periphery, meaning not in the spinal cord, not coming from the brain.
In your arm. So.
Yeah. And so the best example of this is if you hit your hand on a table or something, and then you go to it and you start rubbing it.
Oh, yeah. Well, that's like when they give you a shot that they'll always like rub your arm after.
So that's gate theory. And basically what they think is happening there is that you've gotten this nociceptive input from the original bump. But then you go and overload it with all this other stimulus of your
like rubbing
on your skin. And that kind of confuses it. And so what the inhibitory neuron does is say, well, we're getting way too much stimulus here, so we're just going to cut it off. This can't be painful.
We're confused.
Yeah. And so...
It's like reset.
Right. So that's another way. And as a physical therapist, one of the things they teach you in school is using... TENS units, which stands for transcutaneous electrical nerve stimulation.
So those are like the little electrodes you put on.
So yeah, like Icy Hot sells like commercials where you put the TENS unit on your back and it makes you feel better. So it works the same way. It's sending electrical signals that are kind of overloading that area, and that's using what was originally described as the gate theory to kind of close off that pain signal to your brain.
Yeah, I've used those before. They just feel kind of tingly or tickly, kind of.
Right. And they kind of work, but...
They worked while they were on, I would say.
Right. And what's interesting about that is they probably don't work all the time because pain has a bunch of different inputs. And so that's only taking care of one input, directly, and maybe it has a little bit of a placebo effect too.
Placebo.
We got to be careful saying placebo effect because I'm worried we won't use it right. Pain is a very placebo-y type of topic, though.
Yeah.
So I guess the last thing that we need to talk about in order to really understand what pain is a fancy term called neuroplasticity.
I love neuroplasticity.
Do you?
Yes.
Tell us what it means.
So my understanding, they initially, a long time ago, I don't know, the theory was that when you were a child, when you were a baby and a child, your brain was making connections and as you learned how to do things, and that once you were an adult, it didn't have the ability to really change much.
Right, yeah.
And then neuroplasticity, though, is a more recent theory that says that, the brain can change at any time, that it can restructure itself, that it can, so like in people that have a stroke, that they can, one area of the brain is damaged, but they can relearn how to do things, and another area of the brain can take over those functions that were lost.
Right. We should do a whole episode on neuroplasticity.
Yes.
But for now...
Was I right?
We'll say yes, you are right. I'd say you're right.
Okay.
There are obviously all sorts of intricacies, but that's basically it. So,
and I have heard of it with pain, too.
Yeah, so what you're saying is that the nervous system can change as it adapts to all the situations that it's in.
Yes.
So one thing that we have to talk about with pain and neuroplasticity is this phenomena called central sensitization and also peripheral sensitization. Mm-hmm. So let's go back to our friends, the International Association for the Study of Pain.
Our Seattle friends.
Yeah. And what they say, sensitization is an increased responsiveness of nociceptive neurons to their normal input. Let's stop there.
So nociceptive would be something in your finger, say.
Yeah, so I'm getting a nociceptive input in my finger because I cut my finger.
You cut your finger.
But they're having an increased response. So instead of feeling
a little bit of
pain from the paper cut, I'm instead feeling a ton of pain from the paper cut.
It's a very terrible paper cut.
Right.
Okay.
And the other part of sensitization is that the recruitment of a response to a normally sub-threshold input.
So if something is so minor that you wouldn't even feel it normally?
Usually it wouldn't even cause a pain response, but...
Like a tiny, tiny sliver.
Right, but because of sensitization, it does cause a pain response.
Okay.
So this whole sensitization issue is really what's behind the cause of chronic pain.
Yeah, that's a big problem.
Yeah. Did you know that chronic pain is now considered a disease by itself?
Well, I do see that listed in people's diagnoses, I feel like.
I didn't really, I was just figuring, you talk about it as a symptom or something, but chronic pain is a disease in itself. And it's really not well understood yet. But this is part of it, the sensitization. Mm-hmm. And so...
They just have become too sensitive to stimuli or overly sensitive to things that shouldn't be painful.
So because of the way that nociceptors work, and here's what I understand about nerves, is that they have a constant rate of firing. So say that you're feeling no pain, the nociceptor is still going to be firing at a nice slow rate. Mm-hmm. And then if for some reason they get some input, it starts to increase. Mm-hmm. And that's when you start to notice it. Oh, sorry. I thought someone was at the door. And that's when you start to notice it. Mm-hmm. But the issue with central sensitization, or sensitization in general, is that all of a sudden that normal firing rate, where I was doing really slow.
Don't do it. I feel dark again.
Where I was doing really slow before.
Yeah.
Because of various reasons, but you've been in pain for a while, let's say, that normal firing rate then switches to the faster one. So now it's easier for you to be in this painful situation and for your body to notice from the nociceptive input that you're in pain. Mm-hmm. Does that make sense?
So say you've done something that caused a little more long-term pain, like you broke your finger instead of cutting it. And so you're having more pain for a while. And then something happens and the nociceptors just keep saying you have pain even though there's nothing really going on.
Yeah. So the definition of chronic pain is...
Even though the finger has healed.
Right. Is usually pain after an injury, some type of tissue damage has healed. And usually they say after 3 months, but that's kind of arbitrary.
Well, for a fracture, I guess that makes sense.
Yeah. So, but you're right. Yeah. After after some type of tissue damage has healed, you're still got this long-term pain. And when we think about that, it's because the nervous system has changed. It's used to this pain input that you've gotten from your injury, and it continues feeling that way because of neuroplasticity.
So it's neuroplasticity, even though it's not in the brain?
But it's going the wrong way. Yeah, neuroplasticity can happen in the periphery too.
Okay, which the brain and the spinal cord is central and periphery is everything else.
Right.
Yeah.
But it's really hard to know which type of sense. I mean, in chronic pain, it's usually central sensitization, and that means that the nociceptive inputs coming in might be normal, but the way that the brain is interpreting them is wrong, or so not wrong. It has changed.
It's too sensitive,
and it's heightened the alert that they cause.
So even if it's a very mild input,
from the nociceptors, that might cause a lot of pain because of the way that the central nervous system interprets that input.
Okay.
So sensitization is and chronic pain is probably also a topic in itself.
Yeah, we'll have to do that another time.
But basically, your nerves can change, so the way that you interpret pain is not always the same. And with chronic pain, the way that you interpret pain has changed from before you had that pain. And that's why things seem to hurt, even though people tell you that, oh, you don't have an injury, or it's been so long since your injury. So the pain still exists, but the tissue damage no longer exists.
So then it's just a phenomena in the brain and not something in the tissue.
Right. And it's important to note that, a lot of people who have chronic pain, especially those that feel like they don't know the reason why, it's very distressing, and that continues to perpetuate the pain because of the distressing, because pain is emotional and sensory. And so
I think that if you're sick or whatever and you don't know the reason why, that's much more distressing than if you know what it is and you expect, okay, well, I'll be sick and then I'll get better in this way and this is the treatment.
So one of the worst things you can do, especially for someone suffering with chronic pain, is telling them the pain's in their head. The reality is that the pain is in their brain.
It's their brain, yes.
Which happens to be in their head, but that's not what in your head means.
No, that's not really what the phrase
means. So
the
pain is in your brain, and it's because of a nervous system change, and it's reacting to stimulus in a different way than it used to.
So can it be fixed?
It can be.
Pain medicines, I think, are a short-term fix, but that's not going to solve the brain neuroplasticity problem.
No, so you are addressing a point that I think we'll probably get back to with a series or something.
About pain?
About pain, but you're addressing almost the opioid issue that we're having, because right now pain medicine is overprescribed for chronic pain, probably.
Because it doesn't, if the problem is, like you said, in the brain, I don't see that pain medicine is any kind of solution for it.
Right, it might be treating a symptom that's not the actual cause of the pain.
Right, so it's a short-term fix to get a little more comfortable, I guess.
Right. And I wasn't planning on talking about treatments, especially not treatments for chronic pain.
Oh, okay. Well, we don't have to
this episode.
Now.
But you are talking to a physical therapy student and an occupational therapist.
I'm talking to myself?
Yeah. Well, the listeners. You're listening to a physical therapy student and an occupational therapist. So it's likely that we will promote some type of movement therapy, and
I've heard of some interesting, what's it called? Guided motor imagery.
Okay. All right. So
for chronic pain.
Yeah.
We can talk more about that.
I think we should come back and talk about treatments for chronic pain at some point.
Yes. Okay. So no more on it now, but there are treatments and we will talk about them.
Right.
So stay tuned.
Okay. Exactly.
Not right now, in a later time.
I think that, in summary, that gives us a pretty good idea of the nervous system aspect of pain.
An overview, yeah.
Right. We've also mentioned that pain is emotional and as well as sensory. And that kind of means that your perception of the situation that's causing pain also has effect on the way that you feel it. And the reason for this is people used to think there was one pain area in the brain.
Okay.
But in truth, what there actually is what they call a pain matrix. Basically, there's all sorts of areas in your brain that have to do with pain.
Right.
And all these different factors are considered in order for your brain to make you feel pain.
Okay.
And so there's all sorts of different things. Nociception, or like the nerves that are sensing danger,
The input from the nerves.
are only part of it.
Okay.
Do you want to talk about visceral pain?
Is that like the stomach?
So pretty much what we've talked about so far is acute pain, meaning like an injury.
Yeah.
So something that happens suddenly.
Yeah.
And we've also mentioned chronic pain.
A little bit, yeah.
Yeah. Visceral pain is another type of pain.
Because the viscera are like the internal organs.
Viscera, yeah. It means, basically what it means is pain from your organs.
Okay.
And so have you heard of referred pain?
Yes, that's when your spleen is having problems and it's your shoulder or something like that.
Right. So this is a whole
Your shoulder is where you feel pain.
another topic that could probably deserve its own episode.
That's a strange thing.
What?
Referred pain.
It is. It's super interesting. So the way that I understand it is when you have an issue coming from one of your organs, and you feel it somewhere which is not one of your organs, and it's usually in the skin.
Okay.
Your body doesn't really expect to have pain from one of your organs.
It just thinks they're going to be fine. Stomach's going along, it's fine.
Well,
But you
so
get stomach aches.
probably, yeah, your GI system is actually really connected to referred pain because you often have feelings of like fullness when you eat and stomach aches when you eat something bad.
But then I'm assuming that the problem is in the stomach and it hurts in the stomach area. So that's
Right.
not really referred, is it?
No, so referred pain happens when something that's not usually meant to feel something. And
Like your spleen.
Sure. I'm actually not sure, but let's take spleen as an example.
I never think my spleen's having trouble today.
But if you had referred pain, so the way that it works is that the body doesn't expect that place to have pain. And so it doesn't have a pathway for nociceptors to go to take a signal and then bring it back up to the spinal cord like your skin does.
Not a direct route.
No. So the route that it uses is through sensory nerves. And the way that that works is
Like in the skin. Sensory nerves in the skin, or?
It uses sensory nerve pathways. So the way that that works is that during development, different organs are made at different locations.
Like when you're an embryo.
In embryo, right. And so the way that referred pain works is that places that are... What it really is with referred pain is that they don't have their own way to bring pain to the spinal cord, and they have to use other ways. And those other ways are also used for other things, like sensory stuff from your skin.
So literally, the spleen is like my old friend, the shoulder that I grew up next to.
Yeah.
Is going to help me give this message.
Well, yeah. And so they use the nerves that they have access to. But the reason that you get pain in your shoulder and not in your spleen is because of a phenomenon called convergence. So because there's not their own pain pathway, what happens is that the pain signal, the nociception signal, comes up to the brain, and the brain says, well, it could either be the shoulder area or it could be the spleen. And we don't get pain from the spleen, so it's got to be the shoulder.
It's probably the shoulder.
And
for
so
sure.
that's why you perceive pain in the skin on the shoulder.
Because it doesn't come up any differently to the brain.
We need a disclaimer. We did not look up the referred pain pattern for the spleen.
Oh, is it the shoulder? Look it up. Let's look it up real quick.
Oh, yeah. Okay, it is the shoulder.
I thought I remembered it. Jeez. Okay.
Okay, it is the shoulder. So that's confusing too. But basically, it's this convergence phenomenon where there's two places that it could, or multiple places that this pain signal could be coming from.
Could be spleen, could be shoulder.
The brain looks at them, figures out which one is most likely a place that has pain. It knows that the nociceptors from the shoulder probably have pain, and that's why you start to feel pain in the shoulder, which is far away from the spleen. So that's another interesting part of pain that we don't have a lot of good research on. And as you can see by the way I explained it,
It seems kind of complicated.
It's very complicated, and I'm not sure there's an easy way to explain what's going on.
No.
Did you know there are no nociceptors in the brain?
The brain itself?
The brain itself doesn't have nociceptors. Isn't that
So
interesting?
that is because then if someone was having a stroke, they would say, I can feel it in my brain.
Well, the example that I heard is
Afterwards, maybe, but-
when you're getting brain surgery, usually not unconscious,
Oh, yeah, I've had people that have had brain surgery.
because they just do a local anesthetic for the skin and bone around
Right.
your brain. But the brain doesn't actually hurt when you're operating on
Right.
it,
Well, a lot of times they want you to be awake so that
so that they can make sure they haven't.
damaged an essential
Yeah.
area. Or if they're putting like a deep brain stimulator for Parkinson's.
They want to test to
they
make
wanna
sure it's in
test
the
it.
right spot.
Yeah.
Yeah, so that's pretty interesting too.
Yeah.
That's all I had on that.
That's okay. Have we reached the end of your topic today?
We've reached the end. So here are the things that I want to make sure people come away with.
Okay.
Pain is more complex than just tissue damage.
Yeah. Just
Okay.
because you're having pain doesn't mean there's anything going on in the tissue. It could be from multiple reasons.
Right, all sorts of reasons.
Mm-hmm.
And building on that, pain is a perception by the brain, and it's emotional and sensory, meaning that there's all sorts of different inputs, not just the sense of an injury, but all
Right.
sorts of other things. My third takeaway point is that chronic pain is real pain.
Yes.
It's not pain that's in someone's head. It has to do with a change in the nervous system.
Yes. It's not, maybe it started as pain in the tissue, but it's not pain in the tissue anymore either. It's pain
Right.
in the brain.
Right. And then building on that, our brain does have the ability to modulate or control pain. Now, it's not that we can control it necessarily very well, but there are things that we can do to change the way that our brain is modulating pain.
Which maybe will be the treatment for chronic pain
Right, yeah.
that we
might
can
get into
discuss
it
later
then.
on. Yeah.
But these nervous system changes can either increase or decrease the amount of pain sensation that you end up feeling. And that's it.
And that's it. Well, I thought that was a great overview of pain, brother. I look forward to maybe some more topics about pain in the future.
I think there should be, because
Like chronic pain,
yeah, pain
referred
is
pain, that
pain
I was
is
just full of ideas.
pain is much more specific than one episode about pain as a whole. So
Yeah,
I think
gosh.
we covered a lot of interesting points. There's definitely more to cover, and we'll probably do that in future episodes.
Yay. Okay.
Okay, so for the end, we should say that this is our 6th episode.
Woo!
Thank you for those that have been listening the whole time. If you like the show, feel free to give us a rating on iTunes or share us with some of your friends.
We would appreciate that. You can also like us on Facebook. We have a page, Placebo Podcast, and
Right.
we have our website, placebopodcast.com, if you'd like to see any of our references or resources about the topics we've talked about.
All the information about our show is on the website.
Yes.
So a new thing with Placebo Podcast, we're going to try and tell you what's happening next week so that maybe you'll be excited about it,
To entice you.
to entice you to listen again. So happening next week on Placebo,
Okay, we're going to talk about longevity.
longevity.
Yes, what affects the length of your life and what you can do that changes it.
Oh, and we already have a great intro, don't we?
Yes.
But we won't give that away.
No, but just imagine it's going to be great.
Okay, well, I guess that's it for this week.
Okay.
The Placebo Podcast is produced by Logan Richards and Kaylin Richards, and our music is by James Aiken.
Thank you very much.